Medical management of hypovolemic patients include oral rehydration if a patient is able to do so. Also, patients can be given isotonic fluids to increase fluid volume. Isotonic fluids include lactated ringers and 0.9% NaCl or sodium chloride. Their labs will include increased hemoglobin and hematocrit, increased BUN and creatinine. Nursing management would include I's and O's every 8 hours, assessing the urine, vital signs Q4 hours and with any changes, daily weight, and assessment of skin turgor. For gerontological considerations, we must always assess geriatric patients for hypovolemia because of a decreased thirst mechanism causing them to drink less. Hypervolemia is more fluids entering the body than exiting the body of the patient. Causes that I'm sure you've seen in clinical thus far include patients with heart failure, renal failure, cirrhosis of the liver, and excessive table salt. Symptoms include increased blood pressure, increased respiratory rate. If you listen to these patients' lungs, they will oftentimes have crackles in their lungs and shortness of breath. The patient can even have jugular vein distension and can have weight gain. In addition to that, you can expect a patient with fluid volume excess to have edema. These patients can also have ascites, which is edema accumulating in the peritoneal cavity, and this can cause shortness of breath. Medical management for patients who have fluid volume excess or hypervolemia include chest x-ray to assess pulmonary congestion. In addition, these patients are often prescribed loop diuretics such as Lasix or furosemide. It is very important that when a patient is given Lasix that we monitor the serum value of their potassium and give potassium supplementation as necessary. In addition to this, some patients also have to have dialysis if their renal function is so impaired that other pharmacological interventions do not work if they have renal failure. All patients who have hypervolemia, it is a good idea to promote rest in between activity as they become fatigued easily, and to put them in the Fowler's position to help them breathe. You can expect in their labs decreased BUN and creatinine because of plasma dilution.
The first electrolyte that we are going to discuss today is sodium. Hyponatremia, I want to break that word down for you. Hypo means less than, nat means sodium, and emia means blood. So there is a deficiency of sodium in the blood for these patients. The serum sodium for these patients are less than 135 milliequivalents per liter, and the symptoms mirror fluid volume deficit, which we just talked about in depth. The second is hypernatremia. Hyper means greater than, nat means sodium, emia means blood. This means that there is an excess of sodium in the blood greater than 145 milliequivalents per liter, and the symptoms mirror fluid volume excess, which we just discussed in depth.
Hyponatremia is when there is more water than sodium in the blood. Causes of this can include vomiting, diarrhea, sweating, and diuretics. As far as the symptoms that you will see in these patients, the symptoms are similar to fluid volume deficit if a patient is experiencing slight hyponatremia, but if the hyponatremia gets to 115, it becomes more serious. If the sodium level is 115 or below, the patient can experience some neuro implications, including lethargy, confusion, seizures, and even death. Medical treatment for patients that have hyponatremia include giving this patient isotonic solutions that include lactated ringers or 0.9% NaCl normal saline. The patient can also be put on a water restriction, and hypertonic solutions are given to patients that have a sodium level below 115 with extreme caution in an ICU setting with a lot of monitoring. Nursing care for this patient include eyes and nose every 8 hours or with status change. We want to monitor to make sure that the patient at least has 30 milliliters an hour for normal urine output and to assess the urine. Vital signs, Q4 hours and with status change, daily weight, and skin turgor. It is important to note that if a patient has a sodium level of 115 or lower, it would be wise to institute seizure precautions. These include placing the pad at the side of the bed. If a patient does have a seizure, you need to ease that patient to the floor, clear the room of anything that could cause harm to the patient, such as furniture. You do not want to insert anything into the mouth or restrain the patient, and if possible, place the patient on one side to prevent aspiration. Hypernatremia is when there is more sodium than water in the blood. And this is often caused by those who cannot communicate thirst, such as the very young or very old. In addition, hypernatremia can be caused by hypertonic enteral feedings without adequate water supplements. So if a nurse gives a feeding through the NG tube and does not follow the doctor's orders to flush that feeding with water, for example, every 4 hours, that can cause hypernatremia. Medical management for hypernatremia includes giving hypotonic or isotonic fluids. Nursing care includes focused neurological assessments, reviewing the IV fluids that the patient is on to make sure that they are correct and not causing the hypernatremia, reviewing the patient's eyes and nose every 8 hours or as any change occurs, making sure they have 30 milliliters out per hour of normal urine output, looking at vital signs at least every 4 hours, and daily weights.
We are now going to discuss potassium imbalances. The first is hypokalemia. Hypo means less than, kal means potassium, and emia means blood, meaning that there is a deficiency of potassium in the blood. The serum potassium is less than 3.5 milliequivalents per liter. Hyperkalemia. Hyper means greater than, kal means potassium, and emia means blood. The serum potassium, or the potassium in the blood, is greater than 5 milliequivalents per liter. Before we start our discussion on potassium, it is important to refresh ourselves on potassium's role in the body. Potassium is integral in nerve and impulse connection and muscle contraction, specifically the heart muscle. It's also very important to note, to maintain potassium balance, the renal system must function because 80% of the potassium goes through the kidneys and excreted through the kidneys, and the other 20% is lost through bowel and sweat.
Causes of hypokalemia include diuretics, fluid loss through vomiting, suctioning, diarrhea, hyperaldosteronism, which is when too much aldosterone is in the adrenal glands. This causes a drop in potassium, and anorexia. Symptoms that you will see in these patients include fatigue, anorexia, muscle weakness, decreased bowel motility, and paresthesia. So if you see a patient with these symptoms, it would probably be a good idea to give the doctor a call to get a serum blood test of potassium to see if the patient is hypokalemic. Patients typically do not develop symptoms unless the potassium is less than 3. When this occurs, the EKG will have flat inverted T's and preventricular contractions. And we will go over what an inverted T looks like in a couple slides. It's very important to note that due to the changes in cardiac status, hypokalemia can be life-threatening for our patients. Nursing treatment includes, if it's a slight potassium decrease, they can give potassium oral supplements. Dietary intake of potassium should be 50 to 60 milliequivalents a day. It's important to note foods that are high in potassium that we would want to encourage these patients to eat. These include beans, dark leafy greens, potatoes, squash, yogurt, fish, avocados, mushrooms, and bananas. If a patient has a more pronounced hypokalemia, they will need to receive IV potassium. As I mentioned before, it is very important to establish that the kidneys are working sufficiently by looking at the BUN and creatinine before giving potassium IV to a patient. And you would never give potassium chloride as an IV push. It is always done as an IV piggyback and at a slower rate. Because if we flood the patient's veins with potassium, that can also cause a fatal heart dysrhythmia for the patient. In fact, at many hospital facilities, they require 2 nurses to sign off when a nurse is giving potassium because it can be dangerous if given incorrectly. Here is a visual of the multi-system effects of hypokalemia. Hyperkalemia, some common causes of that include decreased renal excretion of potassium or rapid administration of potassium. Some symptoms include muscle weakness, tiredness, tingling sensation, and nausea. Hyperkalemia also has cardiac implications. These patients can have peaked T waves, which we will look at momentarily, and other dysrhythmias. Medical treatment includes a couple of medications that we'll go over in a minute, and then I do want you to know that hyperkalemia can be life-threatening as well because of the cardiac implications, especially if the potassium is greater than 7. So if you have a patient who has slight hyperkalemia, they will give K-Exolate for these patients in non-acute situations. It's very important to note after you give the K-Exolate, it's a tarry substance that patients drink to make sure that they have had a bowel movement afterwards, because that is how the potassium is excreted. In a more acute situation, calcium gluconate can be given, which antagonizes the action of potassium and decreases the chance of dysrhythmia. For nursing care for these patients, we would want to look at their BUN and creatinine to make sure that it is not because of renal failure that they have excessive potassium. We would want to look at their eyes and nose, look to see if they have any signs of muscle weakness and dysrhythmias. This is a example of various EKGs. EKGs look at the electrical activity of the heart and the atrium and ventricles opening and closing, and it's something that you will study further in subsequent med surges. The first EKG, or the one that is labeled A, is a normal EKG. B is an EKG for a hypokalemic patient, and you will notice that there is a flattened or depressed T wave. This means that there is a decreased amount of blood that is ejected from the ventricles because the T wave addresses how much electrical activity there is as the ventricles are pumping blood into the patient's system. The EKG for C is an EKG for a patient who has hyperkalemia, and you can see that there's a tall peaked T wave for this patient.
Calcium imbalances are as follows. Hypocalcemia is a serum calcium less than 8.6. Hypo means less than, calcium is calcium, and emia means blood. Hypercalcemia is serum calcium greater than 10.2. Hyper means greater calcium, and emia means blood. Causes of hypocalcemia include hypoparathyroid, thyroid or parathyroid surgery, renal failure, and inadequate vitamin D consumption. Signs and symptoms include seizures, confusion, brittle hair and nails. Also, classic signs and symptoms of hypocalcemia include Chavask's and Trousseau's sign, which we'll go over on the next slide. Medical treatment includes supplementation of calcium. Oral sources of calcium include milk, sardines, green leafy vegetables, low-fat milk, and oral supplements. Nursing and medical management include IV administration of calcium salt. It is important when supplementing any electrolyte to carefully read the doctor's orders for the IV rate. Typically these are given at a slower pace, and it's very important that the orders be followed.
Two classic symptoms of hypocalcemia that are important to note include Chavask's sign and Trousseau's sign. Chavask's sign is after a slight tap, the patient experiences a facial nerve tic, and Trousseau's sign is after the blood pressure cuff is inflated to 20 above the patient's normal systolic number, the patient experiences carpal spasms. Hypercalcemia can be caused by malignancies or hyperparathyroid. The symptoms are mild if the patient's hypercalcemia is from 10.2 to 17. These include upset stomach, nausea, and vomiting. However, if the calcium gets to be 17 and above, the patient can experience a hypercalcemic crisis, which includes thirst, polyuria, muscle weakness, nausea and vomiting, diarrhea, and cramps, and can result in cardiac arrest. Medical management includes treating the underlying condition, for example, chemotherapy for malignancies and partial parathyroidectomy for hyperparathyroid. Also, the patient can receive normal saline to dilute serum calcium or IV phosphate. In addition, they can also be given calcitonin or Forticol to decrease the calcium in their bloodstream.
Magnesium imbalances are as follows. Hypomagnesia. Hypo means less than, mag means magnesium, emia means blood. So the serum magnesium is less than 1.3 milligrams per deciliter. Hypermagnesium, hyper means high, mag means magnesium, emia means blood, so the serum or blood magnesium is greater than 2.3 milligrams per deciliter. Before we discuss these imbalances, let's refresh ourselves on the role of magnesium in the body. It is absorbed in the small intestine and is excreted by the kidneys. It helps with blood pressure regulation. It is also important in the regulation of the parathyroid hormone. The parathyroid helps regulate calcium levels. Therefore, you will notice that magnesium and calcium have a direct relationship. This means that if magnesium is increased, calcium will also be increased. On the other hand, if magnesium is decreased, calcium will also be decreased. When discussing the cause for hypomagnesia, it is important to keep in mind the role of magnesium that we just discussed on the previous slide. So, a patient can become deficient in magnesium if there is suctioning or any depletion of the GI contents of the GI tract that can happen through nasogastric tube, diarrhea, or fistulas. Also, if there's any malabsorption issues, such as a patient with Crohn's or celiac disease. In addition, the excessive use of loop or thiazide diuretics or any increased renal excretion can cause a depletion of magnesium. Also, it's very important to note, if a patient is a chronic alcohol abuser, you must always measure magnesium when they are detoxing. Alcohol can cause a rapid depletion of magnesium in these patients. As far as the signs and symptoms, you would want to assess for signs of hypokalemia and hypocalcemia, because typically these cause the patients to have hypomagnesemia or depletion of magnesium. And whenever you are treating for hypomagnesemia, you have to get that potassium and calcium to a normal range for the treatment to work. Some signs and symptoms that mirror depletion in calcium include Chavask and Trousseau sign, decreased in energy, and decreased bowel motility. Medical management includes getting some sort of a heart monitor on the patient to make sure that they don't have any cardiac changes, get an EKG. If there's a slight deficiency, you want to encourage a rich in magnesium diet. This can be found in dark leafy greens, nuts, seeds, fish, legumes, whole grains, peanut butter, and cocoa. Other medical management includes giving IV magnesium sulfate. It's important to follow the doctor's orders and not to exceed 67 milliequivalents over 8 hours. IV magnesium given too quickly can cause the heart to stop. Also, before magnesium is given, it is very important to assess the function of the kidneys. You need to look at the BUN and creatinine so that you do not cause hypermagnesia. Also, for these patients, it's important for nursing management to have seizure precautions in place and do dysphagia screenings. Hypermagnesium is rare. It usually only happens with renal failure. It can also be caused to a decreased elimination due to decreased intestinal motility. Signs and symptoms usually mirror the signs and symptoms of hyperkalemia and hypercalcemia because these conditions are related to hypermagnesium, and again, they have a direct relationship. Signs and symptoms also, if it's greater than 10, these patients can have respiratory depression and coma can occur. Medical treatment includes making sure, first and foremost, not to give magnesium to renal failure patients, like I mentioned on the previous slide. And then also you can give IV calcium gluconate, furosemide, which is also known as Lasix, to these patients. Nursing care includes assessing for hypotension, shallow respirations, assessing level of consciousness, deep tendon reflexes. Phosphate imbalances include hypophosphatemia. Hypo means less than, phosphate means phosphate, and emia means blood. This is a serum phosphate level of less than 2.5. Hyperphosphatemia is hyper means more, phosphate means phosphate, and emia means blood. This is a serum phosphate of greater than 4.5. It's important to remember that phosphate builds bones and teeth and nerve and muscle function. It's stored mainly in the bones. Phosphate and calcium do have an inverse relationship, as previously discussed, and vitamin D plays a role in absorption of phosphate.
Hypophosphatemia can be caused by nutrition replacement, such as TPN, without adding phosphorus, and alcohol withdrawal. Symptoms include decreased energy, irritability, weakness, confusion, or seizures. Medical and nursing management include for mild hypophosphatemia to encourage foods containing phosphate, which include milk, nuts, and fish, and for moderate, patients can take phosphate supplements. Hyperphosphatemia is usually caused by renal failure. Symptoms are few. They may include tetany, which is muscle spasms, anorexia or nausea and vomiting. Clinical and nursing management include calcitrol, which decreases the serum phosphate level and binds to phosphorus in the GI tract.